Okay, I call this meeting to order of the Lincoln County Public Budget Committee, or the public budget hearing for the Lincoln County Budget Committee. It is May 22nd, 2023, and it is 6 p.m. Introductions. First, let's just talk a little bit, or should I open the public hearing first and then do introductions?
I think generally we do introductions and then,
Let's
well,
start.
technically these aren't public hearings. I mean, it's a budget committee hearing, but
Okay.
I don't know if that makes sense.
All right, well, let's start down here at the diocese with
I'm Commissioner Jacobson.
John Heath,
Casey Miller.
Claire Hall.
Kathleen Kelly.
And we have our Health and Human Services team with us tonight. So let's open that public hearing officially and begin by your introductions.
Very
Good
My name
evening.
is Jane Romero, and I work as the Lincoln County Health and Human Services Director. My name is Brandy, and I'm the running secretary.
Good evening. Well, we've got a few adjustments here and then let them get set and you can take it away. Okay. Well, that is the Public Information Officer, Ken Lip.
I was just gonna say one thing, Commissioner Miller, if you could hold up that gavel real quick.
Wait, Katie Jacobson.
All right, just point it out.
Thank you. Good evening. Hi. Yeah, be great.
Good evening. We are here to present the fiscal year 23-24 budget request for Health and Human Services. And this is all anything, right? It's like, very good. Thank you. So Health and Human Services is the largest department in the county. We are comprised of 4 operating funds and 29 fiscal departments. And the language gets a little tricky because we are the department, but we call our fiscal budgets departments as well. So there are 29 of them.
Wow.
And basically our mission in the county is to foster the health and well-being of the citizens of the county within the parameters of the funding that we receive. So we have 4 operational funds. They include behavioral health, intellectual and developmental disabilities, primary care, and public health. Each of our divisions has a division director or a deputy director. We also have a division for quality and risk management. We have fiscal staff and we have administrative staff. We have 184 budgeted positions. And the majority fall in our behavioral health division. Behavioral health makes up about 42% of our overall budget, with public health coming in at 22%, primary care at 29%, and developmental disabilities at 7%. We currently have 31 vacancies. We have a 17% vacancy rate, and that is good for us. We are doing well. You will see our budget grid here. Our overall budget is $42,874,000. And you can see how it falls out. A little, about half of it is invested in personnel services. A quarter of it is in materials and services. And another quarter of it is in what we call contingency funds. And contingency funds maybe includes our fund balance that we carry over from prior years. It includes funding that we would need if staff left and needed to cash out their vacation and their sick leave. And sometimes it just covers the fact that we have funds that we don't intend to use for another fiscal year. So you will see those in most of our funds, but in total, it's about a quarter of our budget. We have about 300 funding streams. And the major funding streams are represented here. Our biggest funder is actually Medicaid. So we receive Medicaid funds through the Intercommunity Health Network. And we also bill directly to Medicaid for people who are on the Oregon Health Plan. And this makes up a little over 9 million of our entire revenue. We get funding from Medicare. That's primarily through billing with primary care services. We bill for a third-party insurance, of course, in our health divisions. We also have people who pay privately on a sliding fee scale for the services that we provide. We get a lot of funding from the Oregon Health Authority. That tends to hit our behavioral health division as well as our public health division. We get money from the federal government, which is through HRSA, the Health Resources and Services Administration. That's about 1.4 million. We have recently received funding through the American Rescue Plan Act, although that is closing out. So you'll see in some cases the revenue for this year is less than prior years, but a lot of that is tied to ARPA funding. We get marijuana tax through money from the county. The Department of Human Services funds our developmental disabilities division. Through a contract with the Department of Veterans Affairs, we are able to provide the Veterans Clinic and our primary care division. And we get a number of other fees, franchise fees for solid waste, license and permit fees from environmental health through restaurant licensure, pool licensure, that sort of thing. We get a small share of the liquor tax. We also receive incentive payments from the Intercommunity Health Network for achieving quality metrics. I'm pleased to say we have received everything we could receive this past year. There's interest, other grants, and of course, the fund balance that we can together. Most of the funds that we receive are restricted. So restricted meaning that we may use them in defined ways. So for example, the funding that comes into behavioral health from the Oregon Health Authority comes in specifically to provide mandated services for people who are un- and underinsured and so forth. The latitude that we have is in funding that we earn through third party, through healthcare, through the delivery of healthcare. Those funds are restricted in the year that we earn them, but in like the next year, there's some flexibility in how we can use those funds. And I think it's kind of important to bring that up because I know periodically people wonder, well, how can you buy this or how can you do that if the county is, really watching its budget? And it's really because we have these funds that are dedicated, they have specific uses, and in some cases, we're able to carry them forward. We are asking for $625,000 in general fund funds this year. We use those funds as a Medicaid match to match the programs that we provide in public health through our maternal child family health programs. These are, and you're going to hear more about that a little later on, but these are programs that support pregnant women, infants, toddlers, and disabled children up to age 21. We, in most cases, for most of the Medicaid dollars that we get, the state puts the match on the table. But for these funds, the state requires that the counties put the match on the table. So this $625,000 really allows us to leverage a total of $1.8 million. Funds a minimum of 14 of our physicians, but if we have revenues exceeding the costs in the maternal child family health program, we use those funds to support our WIC program, Women's, Infants, and Children's program. That program in this county and across the state is underfunded, and it right now even operates at a deficit of $275,000. So this pot of money that we are requesting from the general fund really finances services for this county's youngest citizens and their families, but more on that later.
Yes,
Yeah.
Chair Miller. On the matching funds with the grants, can those matching funds be supported by grants?
No, they have to come from earned revenues
Thank
from
you.
the governmental sector.
Thank you.
Good
And
question.
is that a federal requirement?
Yes.
Yeah. Okay.
I thought we could get in there somehow and we can't. Thank you very much.
Yes, well,
All right, and so this is just a pie chart of the information that I just. So I'm going to talk a little bit about the major achievements in Health and Human Services. You'll see some of this presented again as we go through our divisions. But these are pretty big achievements for us, and I think it's important to note that an achievement that might hit, say behavioral health is really not just limited to behavioral health, because a lot of people have to contribute across administration and, just across our whole entire operation for things to actually materialize. So a couple that we're particularly proud of include our building expansion, consolidation, and savings. We purchased and opened a clinic in Walford in August of 2022, and we were able to provide primary care, behavioral health, and other services from that clinic. Operating services in South Valley has long been a goal of the county, and particularly of the shared governing board that we have in primary care, because we really just have no way to reach South County residents. So a big achievement for us. We have just completed a remodel of our Nice Street building, and we moved the Newport-based primary care clinic out of the 1010 building that it's been operating in for longer than I've been here, and I'm not sure how long that is, but for a very long time.
2006.
History.
Yes.
So we've been able to renovate and move them into a more spacious, more professionally appointed clinic. And this is really important because we are a healthcare provider, physicians and nurse practitioners. And we know from the literature that people equate the quality of their healthcare with the attractiveness and professional environment that they work in. And so this is a big achievement for us. We have just recently completed the purchase of the building located at 255 South Highway 101. We will continue to house our developmental disability staff, our maternal general family health staff in there, but we will use the building also for administrative staff, our environmental health program, and a lot of our public health staff, our communicable disease and health prevention staff will come up with that. Because we have these facilities, we're ending leases in the 1010 building that we've occupied since 2006. And we're also ending the lease in another facility just across the street that has been the site for some of our public health staff. We have secured funding for a 28-unit apartment complex to support individuals who have a serious mental illness. We have also purchased a facility for a house that we're going to stand up a crisis stabilization unit. We have been, oh, no, I'm sorry, I slipped a slide. Okay, we've been able to hire a bilingual psychiatrist, who can treat all clients of all ages. That's really a pretty big coup for us because psychiatry is an incredibly scarce specialty, and when you find somebody who is actually bilingual, is pretty major. We actually have 20 bilingual staff who have passed some level of testing and for which they receive a stipend so that they are able to support the members of the community that identify as Hispanic. And that's very important to us. We really want to make sure that our Hispanic community feels that we are here to support them and that we can support them. We're hosting a pharmacy on site in our Nice Street and Lee Street buildings, which is also a major advantage for the folks that we serve. And I might add that anybody can use the pharmacy, but county employees, just anybody really, they just don't market, but our contract providers, our community partners, all of the patients that we serve are able to get their prescriptions filled without a line in our own facility. And we closed out a strategic plan that we launched just ahead of the pandemic. It was technically our 2024 strategic plan, but we found that we had achieved most of the objectives just because, or they no longer mattered because of the circumstances of the pandemic. So we closed that out, and there was a presentation here in front of the Board of Commissioners. We've been recognized as a health quality leader for 4 years now, and this is an award given out by HRSA, by the federal government, for those federally qualified health clinics that achieve a certain level of excellence. And so we are in the top 20% nationally There aren't a lot of Oregon FQHCs that meet this standard, so something we're a bit proud of. We're also recognized as a patient-centered primary care home by the state of Oregon and have been since 2013. And in order to achieve that level of recognition, we have to demonstrate compliance in 6 areas. And the level of achievement that we have as a patient-centered primary care home dictates our funding. So you can get up to 5 levels. We are a level 4. And so this is, you know, it continues to be a good thing for us.
Chair Miller, excuse me. The certification, how do you get to 5?
Well, we're working on that.
How can we as a community, how can we as a county help you get there? Because I mean, we're right there. Why not be 5? Why not be 5? Why not be on the top? Why not be top shelf, right?
So a lot of it ties to quality incentives and
Okay.
The degree to which we meet certain health indicators and those sort of things. And so it's really just having a plan in place and working it with our staff and just applying.
Okay.
Yeah.
Thank you very much. Thank you, Mr. Chair.
Thank you.
Thank you.
Let me see, we wrapped up COVID. We're really proud of our COVID response here. We were generally in the top, 3 to 4 counties in terms of community members who are vaccinated, especially as the vaccines were
that's right.
rolling out. And because of the ARPA funds and other funds that we've gotten in public health, we've been able to really just expand the staff that we have available to address emergency preparedness, to address COVID and do data analysis, communicate with the public and so forth. And we have just wrapped up a assessment, a diversity, equity, and inclusion assessment, which will enable us, I think, to do a better job of supporting the diversity of our staff, but also do a better job of making sure that we are inclusive in terms of supporting people in the community. Health equity is a big goal because we know from the literature that that minority populations don't enjoy the same level of health and care as our majority populations. So this is something that we're putting attention into. With regard to goals, we are working on a new 3-year strategic plan. We, as I just said, intend to give focused attention to diversity, equity, and inclusion. We are working to complete our new Newport-based staff relocation process, and then we hope to stay put for a good long while. We will continue to work with the Oregon Coast Community College to establish some educational programs. I mentioned it in here the other day, but just for the sake of this meeting, we are working with the community college to start a certificate program, a 1-year certificate program in health and human services that will prepare people for very basic entry-level jobs with us, but also throughout the community. They are going to bring back an associate degree in psychology, which will allow a transfer pathway to Oregon State University so an individual can get a bachelor's degree. And then they're planning to stand up an applied science associate degree, a 2-year applied science associate degree. Most of those credits will be transferable, but it will be a terminal degree. And that degree plus 1 year of experience will qualify somebody to be a case manager, of course. So we're just really trying to commit and look for strategies to support folks who live in Lincoln County to step into the positions that we have.
Chair Miller, if I may ask, on internship in the county, do you support the students out of that college in an internship with the county in your department?
We do support interns, not necessarily right now out of the community college, but out of the degree programs. And in fact, I believe we had 2 interns and we just hired them.
Thank you. And how's that? I mean, and then moving forward in the years coming, are we expanding that program so we continue to grow with the community college and have a sort of a employment vehicle, if you will say, through the college and through our young, yeah, and I'm just thinking that a mentorship within the county may be a possibility. I don't know if that's something the department has looked at.
Well, I think we're interested in really turning over all of the staff development rocks we can possibly find. Commissioner Jacobson linked us to the community college, and I think once, and this will take some time, but we're working it together. But I think from there, for us, we need nurses. So we're certainly gonna want to work with the community college on that front as well.
Well, exactly. Thank you.
Yeah.
Thank you.
Successful nursing program. It turns out lots of people in this that stay in this community. And so I think the goal here is to try to do the same thing, but more on the mental health and behavioral health end, because we already have kind of a care in the
Excellent.
community college. So we'll see. We're in the beginning, but it's exciting.
Well, it's interesting. I mean, I think there's an avenue there, as Commissioner had mentioned. So, thank you. Thank you. Thank you,
And so
Commissioner.
I think with that, we will jump into our divisions, starting with behavioral health. And our deputy division director for labor is here. And Maria, that everyone can
Director Romero, as Marie's coming up, where are those other federally qualified health centers off the top of your head? Do you know which communities are located? Is Ashland one of those?
I don't know if Ashland's one, Benton County and Benton Lynn has an FQHC.
Okay.
Pierce County has two. Clackamas County has one. They're not all like ours. So we're considered a co-applicant,
Mm.
a public center FQHC, which means that they're shared governance. The county's responsible for certain aspects of the federally qualified.
Mm.
We have a committee that, a board of directors that is responsible for other aspects of it. It's well defined, co-applicant agreement. Many of
Okay.
them are freestanding, but
Mm.
there are about 6 public centers in the state.
Okay, thank you. Can you reach it? There you go.
Thank you. I'm Marie Labor. I'm the Deputy Director of Behavioral Health.
Hello again.
Behavioral health services covers addictions, mental health, and co-occurring disorders. Co-occurring disorders means individuals who may experience symptoms related to substance use and mental health, medical and mental health issues, developmental disabilities and mental health issues. And currently, the population of people we serve with co-occurring disorders are folks with substance use disorders and mental health concerns. We are seeing an increasing number of folks in the latter two groups, especially as the population in Lincoln County ages and expertise in some of these specialty populations dwindles. When we talk about behavioral health, we look first and how to do when we talk about behavioral health, we look first at how to do symptoms that one experiences impacts their functioning. Almost everyone has experienced some level of emotional response to a specific circumstance, and that response may be short-lived, and it may impact only our ability to work, socialize, and live is very minimal. Others, as a result of situations often outside of their control, experience more significant loss of functioning as a result of their mental health. In its most serious state, a person may struggle with wanting to live, is unable to feel a sense of contribution beyond themselves, whether it is through work, volunteering, education, enjoying a hobby, or has difficulty enjoying meaningful relationships. Behavioral health covers the compendium of individuals, whether it be in behavioral health services through our FQHC or our specialty services in the behavioral health division. For this evening's presentation, we're going to focus mostly on those folks affected by mental health, substance use, and co-occurring issues, and served by our behavioral health division, often referred to as specialty mental health. The adults we serve tend to have chronic conditions that often can be treated well with therapies provided by qualified mental health professionals and qualified mental health associates, medication evaluations, and support by our medical team, which includes our psychiatrists, nurse practitioners, and clinic nurse. We also provide resource navigation and skills training.
Our staff not only provide services directly, but advocate and collaborate, consult and provide prevention and education services to the community at large. We serve youth ages 0 to 18 and adults of all ages. We serve community members throughout the county. Between 20 to 30% of the individuals we serve are from Newport zip code. Between 20 and 25% are in the Lincoln City zip code, the rest by other communities throughout the county. Next. The major revenue sources for our division is the state through what we call service elements and also the insurance payments that we receive by the Intercommunity Health Network, which insures those individuals on the Oregon Health Plan. State funds address specific populations or services, usually those not covered typically by insurances and which have significant risks to them. They're considered mandated services that as a county, which in Oregon is usually the designated mental health authority, must provide or oversee. For us, these services are things like our crisis services, our mandated assessments of youth who are placed in DHS custody, our investigations of individuals being considered for involuntary commitment to mental health treatment, individuals adjudicated to the mental health system who've been charged with a crime, others who are determined to be unable to aid and assist in their own defense. In each of these situations, our providers wear 2 to 3 hats. They can be a forensic evaluator, a treatment provider, and to some degree, compliance officers. We work closely with many other state and local providers, the courts and law enforcement. Not all of the people we serve, in fact, a very small percentage of the folks we serve are mandated clients. Less than 20% are, and I want to emphasize that and want to repeat that a small percentage of the people we serve are mandated clients. I don't want to contribute to the stereotypes and myth that most people who seek mental health services are more prone to commit crimes. In fact, Commissioner Hall so eloquently stated in this year's mental health symposium that most individuals who experience mental illness are victims of crime. Everything from bullying to financial exploitation, abuse, neglect, and assaults at all levels. Often just because they have a mental health issue. Sorry. The other largest source of our revenue is in the form of capitated payments through the Oregon Health Authority through our local CCO, which for us is the Intercommunity Health Network. There are currently about 17,000 people in Lincoln County who receive the Oregon Health Plan. This is up from pre-pandemic years, and we are expecting a decrease in the number of people served this year and next, while expecting a significant increase, about 30% in the rate of per member per month reimbursement. Not surprisingly, the largest expenditure in our budgets are like other departments, our personnel expenses. While we continue to experience an overall workforce shortage in behavioral health across the nation, Lincoln County was hit very hard with workforce shortage during the pandemic. And we are slowly rebounding with almost doubling the number of professional staff in the past year, with room to grow. Admittedly, in order to serve the folks we are charged to serve, we have had to look at working with staffing agencies and contractors to meet the needs of those we are charged to serve. And we have been very lucky in finding quite qualified and competent individuals to work with us and with our clients. The materials and services to support the staff and the work we do is our second biggest expenditure. And this includes our administrative support for contracts, human resources, billing, quality assurance, IT, as well as everything from pencils to phones and computers, training and cleaning services for the building. The major activities in our department, the service delivery, is everything from assessment to treatment and includes wraparound services and advisory support. We provide services in our offices on Lee Street, in Lincoln City, and in Walport, in our school-based health clinics, but also where people we serve are in the community. We serve people in their homes, at the emergency rooms, in jail, at the juvenile department. We go to doctors' offices, agency offices. We go with law enforcement, seeing people on the streets when necessary. Our staff must be both generalists and specialists. They need to understand large systems and be experts in their professional crafts. It is not a coincidence that many people come to the county system for training and experience and support towards licensure. And then once the licensure is achieved, is a person really wanted to, if a person really wants to do office-based counseling, sometimes they leave the county to do other work. Public service is hard work, but public service, in my opinion, and in my experience, is the most rewarding work there is. The BOC and the budget committees and the community members, by the power of their voices and their votes, have been very supportive of our department over the years. Over the past 2 years, as a result of savings, grant writing, good fiscal management, we've seen some significant accomplishments in our programs. Schools reopened after the pandemic closures, and we expanded and adapted the types of services in our schools to meet the changes in student and staff needs as we learn more and more about the impact of the COVID pandemic on youth's social, emotional, and educational struggles. We are seeing an increase in the need for urgent response to youth in crisis and have worked closely with schools to provide intervention and follow-up services with schools and youth. We have secured funding from the state through grant writing and support to stand up our crisis resolution center, the development of a 28-unit supportive housing project, and to expand our harm reduction program and medical assistant treatment program. And we are able to offer recognition to our staff who stayed with us through COVID and those with longevity with us. You just did. Okay, you're ahead of me, Jane. We've opened our clinics in Walport. We've co-located child and family and adult services, and then most recently the FQHC in Newport, creating the possibility of a one-stop shop for everything public health, primary care, and behavioral health care. We have been identified as the coordinating entity for the burn in our county. And once again, we've earned 100% of our incentive funds for meeting the IHN quality measures. For us in behavioral health and in all of HHS, it's more than just numbers. It's about the quality of work we offer, because the #1 goal is to earn and maintain the trust of our community we serve, so that we know we can be counted on to provide professional, competent, relevant, respectful services, no matter which door they enter, no matter how many times they enter the door to our behavioral health services. Things don't stand still in healthcare, and we're always looking forward, in part to be responsive to the changing landscape so that we can remain relevant in our fields, but also in response to community identified needs. There are many projects you'll be hearing about in the coming years related to behavioral health services. We want to expand the crisis response to a 2-person mobile response team in coordination with the federal 988 crisis line. We will be opening our crisis stabilization program. We'll be developing summer activities and groups to help youth who have been in treatment. We're going to increase our presence in the community by offering more prevention, mental health education, and outreach activities. We will focus on a model of rehabilitation and recovery that relies on group intervention that effectively and efficiently meets the needs of clients, and which can be delivered by non-licensed trained staff. And will complete the reorganization of the division to compensate for mental health staff shortages. This slide shows you some of the important numbers of the people we serve and the major types of services provided in 2022. It's been a year of looking at our staffing needs. We've been very fortunate in many ways. We have contracted with a bilingual bicultural psychologist who has experience in servicing all ages and with a full breadth of mental health support needs. This will also allow us to provide more services, not only to our enrolled clients, but also to individuals who will be coming to our services. We can more readily accept community referrals with this increased capacity. We've been focused on building our own and growing from within. We're supporting current staff to seek further education. Associate level staff and others seek bachelor's degrees and master's degrees. We're partnering with OCC to build a certificate program, and that will transfer to human services. We want to help support individuals who live locally and want to give back to their communities, whether it is with us or the county or other local community service providers. Our staff is interested and excited to contribute to this partnership as mentors, instructors, and consultants. HHS is committed to the important role as a respected and sought out community partner. And with that, I want to thank you, the board and the committee, for your ongoing support of our department.
Thank you.
Just one question. The co-occurring disorders, challenging from a legal perspective, maybe just a couple examples of why that is.
Say that again, why it's challenging for me.
Yeah.
The risks, there are some risks with folks who present with co-occurring disorders. And one of the things that we're struggling across the state is the issue from the state of wanting us to serve people who are released from the state hospital
Mm,
in very short order, and really without regard to what's available in the communities to support them.
gotcha. Okay, thank you.
Chair, I have a couple of questions.
Yes, of course.
One is you had a specific metric, and it was for crisis service contacts.
Mm.
Can you explain exactly what that metric is and what is considered a crisis service contact versus like a regular appointment? Like, what's the difference?
Sure, when we are, we have staff who are designated as crisis response folks, and they are sort of at the ready to respond to currently the emergency room primarily, both in North Lincoln and here in Newport, or to Walport, to law enforcement, when they're kind of serving somebody in the community that they identify as potentially having a mental health issue. And our job is to go out, do an assessment, kind of on the fly, make a determination of what's going on and develop a plan, whether it's to a higher level of care or more, hopefully to provide some sort of support to keep them in the community with additional supports.
Got it. And then kind of a follow-up question is the crisis assessment, crisis resolution facility, I'm guessing ties into that in some way. And I think we've heard about it from the board previously in this number of meetings, but can you tell us kind of more about that? What types of things would a person go there for? And how does that system work? Is it just for adults? Is it for children? What does it mean being a 23-hour clinic instead of a 24-hour, for example?
Good question. I was wondering about that.
So I'll answer that part first. One of the things that comes with being a 24-hour facility is that then it becomes a residential facility.
Mm,
Comes with a lot more kind of rules and restrictions, becomes potentially harder to staff, to be frank. There is currently a 23-hour resolution center in Deschutes, which is the model that we are looking at particularly. They report that the average length of stay for their folks is 11 hours.
Oh.
So the idea is that folks who currently the only place they can go if there's an emergency is either to our office during business hours or to the emergency room. And many folks, well over half, probably close to 3/4 of the folks could be served at a lower level of care with the right kind of supports. So the crisis resolution center will be staffed by the crisis staff, by skills trainers, and we'll have a nurse there to do some of our medical screenings to make sure that they don't need to be seen in the emergency room. And the goal is that they would be there to receive to get some respite, just time away from either stimulating overstimulating environment, but also a place where they can get the services that they need.
And adults, kids?
Adults to start out, we don't, it's a 5-bedroom house and we don't want to necessarily mix the two. It's a good start.
That's all the questions I had.
For me, thank you.
Anything, Tom?
So then we'll move on to our
Thank you,
intellectual and developmental disabilities division, and our deputy division director, Gingy Limalacina, is here.
Good
Hi.
evening.
Greetings.
Hey,
Greetings.
my name is Chinji Vimalasena. I'm the Deputy Director with the Lincoln County Developmental Disabilities Division. And then we'll just go through the slides. The Lincoln County Developmental Disabilities Program supports eligible adults and children with intellectual and developmental disabilities, and we also support their families. Our services are voluntary, they're choice driven, and if an individual chooses to have our services there with them, our services are with our individuals throughout their lifespan. So our program strives to provide quality services grounded in person-centered practices while maintaining a high standard of compliance with governing rules and regulations. And our funding source is the Office of Developmental Disability Services that falls under the Oregon Department of Human Services. And I think if you go to the next slide, you can see how our funding falls out. Personnel services is about 51% of our expenses. Materials and services, 41%, and contingency is 8%. Again, we have mandated services. Our program has mandated services that we need to offer our community through the Office of Developmental Disability Services. The first is to determine eligibility. So we're responsible for determining eligibility for individuals to access developmental disability services. And we have 2 trained eligibility specialists on staff, and one of them wears other hats as well, including abuse investigator and assessor. We are required to mandated to provide case management services. Our case managers carry a caseload around 50 to 60 clients, and they support children and adults. So they have mixed caseloads of children and adults. They provide case management in homes, in foster homes, in residential homes, and in any setting that you find where individuals are. We're also responsible to provide protective services and abuse investigations for adults with intellectual and developmental disabilities. And then we do licensing and certification of foster homes, both children and adults foster homes. And we have 9 adult foster homes in Lincoln County. In terms of,
Can we pause for a second?
sure,
So those are not DHS foster homes.
No.
That's done for DHS. These are specialty
yes,
foster homes.
yes.
The numbers probably gonna be better, John.
Yeah, no, thank you, Commissioner. Yeah, that number sort of got my attention, so thank you. Thank you.
Yes, and sometimes we contract with child welfare, so DP funds can pay for children in child welfare certified foster homes, so there's a relationship there.
Yeah, I think John was shocked at the 9, thinking that was all the foster homes, and unfortunately, it wouldn't say the numbers, probably a whole lot better if you called DHS.
Yes, thank you. Thank you,
Yeah.
Commissioner Jakes. I was just, my goodness, yeah, that we need.
And we do need both child welfare and DP.
Thank you.
Gingy, quick question there on that Shangri-La. How many years do you recall when those were closed, and is there any overlap there?
Unfortunately, Shangri-La was our only provider here in Lincoln County that provided supported living services. And they had an employment, they were an employment service provider. And they had a number of residential homes, and during COVID, just difficulty managing and maintaining staff, they shut down their services here in Lincoln County. So I cannot remember the exact time frame. It was around a couple of years ago, I want to say.
Yeah, okay.
So with that, we lost a type of service that Lincoln County no longer can offer in
Okay.
terms of supported living.
Thank you.
And then the first bullet point in terms of accomplishment, I would like to preface that really our intent is to support individuals to live as independently as possible in their own homes and in their community. So really the success is that the vast majority of the individuals we serve, we're able to support in their own homes and help them participate in their community. But sometimes either individuals have crises, or there's concerns around abuse, or their support needs are just greater than what can be supported within their own homes. So when these kinds of situations happen, we need to help individuals find placement out of the home. So in this case, last year, we were able to place 5 individuals needing residential placements due to allegations of abuse, needing a higher level of care, or experiencing crises. For a small division, we have 12 staff. We participate in multiple advisory groups, and we facilitate two local interagency meetings. We facilitate the IAPT meeting, which is the local system of care meeting, and we also facilitate a cross-training, quarterly cross-training with our partners from child welfare, behavioral health, child and family, juvenile department, developmental disabilities and self-sufficiency program. So we're just doing a lot of work in terms of engaging with our partners to better serve our clients. Sorry. A bit more there. So we did license a new foster home last year, and then we were able to establish access to long-term community care nursing, which was a service, again, because of lack of capacity, lack of providers, our clients did not have access to, and we were able to make that connection this year to support our clients in that way. Our goals and objectives for this year are very much in line with those of HHS as a department. We are working on reviewing and updating our policies and procedures. We completed a service equity assessment and are working on finalizing that plan. We're continuing to focus on productivity. We're able to meet our monthly case management funds. We're able to meet those every month. And then also in terms of continuing to focus on quality of services, but also compliance with the expectations from the state. Again, along with HHS priorities, we're working on employee orientation and on onboarding, and then just an ongoing commitment to staff satisfaction. We served 260 individuals with intellectual and developmental disabilities in 2022. That was a 6% increase in the number of individuals served since 2021. And with the strategic plan that we're working on, and the outreach we're doing, especially around improving access to services, we expect that number to go up. And we're actually already seeing an influx of intakes. So I think we're just getting the word out that we're there and that our services are there for people, doing a better job of that. Thank you.
Any questions?
Yeah, I have a question. You said
Yeah.
that you were working on improving your access to service. Being a foster parent, as long as I have been, I mean, what generally at least that community, what generally is believed there is it's just really, really hard to qualify. And so, and kind of your goal in improving access to service, is that changing that metric so it's easier to qualify, or is that just kind of letting more people know about it and hopes that you've reached that low percentage that does actually qualify?
Yeah, unfortunately, the criteria for eligibility is set by the state, so there's not much that we can do in terms of changing the criteria. What we're trying to do is support people with that process because it is a very complicated process. Do a better job of supporting people through that process, eliminating kind of looking at our internal processes and eliminating any barriers that we may have. And just reaching different populations and bringing awareness about our services.
Yeah, I think that's helpful. There's a lot of kind of like, why bother? That I hear in the community, especially with people that have been through a lot with kids or whatever. And I think part of that is that criteria is, it's difficult to meet, but I think also the process is a little bit daunting. If you've been through before and it wasn't successful, you may not want to try that again. Especially if things escalate with a particular person, maybe they're seeing more issues than they were when they were younger or whatever. So I think that outreach and looking at your internal processes would be good. Yeah.
Thank you.
Thank you.
Appreciate it.
We'll move on to the primary care division. The division director and Robin is on vacation this week and she's on vacation this week, so I'll be presenting the next two divisions.
Okay.
So primary care is actually made up of the 4 fiscal departments, as we call them, but 3 primary functions. The first is that primary care is our federally qualified health center. And as a federally qualified health center, they provide primary health care in 3 clinic locations, Waldport, Newport, and Lincoln City, and in 4 schools. So Taft, Waldport, Newport, and Toledo. They're also the office-based addiction treatment program. So we refer to it as OBAT, but it is a medication-assisted treatment program. That program is funded with Measure 110 funds and through billing. And we, as I mentioned earlier, through a contract with the Veterans Administration Department, provide healthcare, primary healthcare for veterans identified by the department for us to serve. With regard to the FQHC, though, the funding mix is about 50% Medicaid, again, through the open card or through the IHN CCO, about 15% Medicare, 20% traditional third-party reimbursement, 15% self-pay, and as I mentioned earlier, we get about $1.4 million from the federal government through HRSA. So this is the funding profile, and the budget this year for primary care is just a little over $7 million. And again, you'll see that slight decline there. Primary care has will not be getting our funding again, so that's kind of why you're seeing the decline there. And then here's our pie chart. Again, personnel services make up the largest piece of the pie at 62%, with materials and services at 25%. Major activities include serving as a full-service primary care clinic for the 7 sites within the FQHC. They provide family planning and reproductive health. They provide behavioral health services, immunization. Through a voucher program, we're able to help people get dental support. We make referrals to specialty services, social services, in-house behavioral health services. Again, the medication assisted treatment program that we call OBAT, and the Veterans Administration contract that I mentioned. Recent accomplishments, and some of these you've heard before, so I'm just going to go quickly. We opened the Waldport Clinic, we've moved the Newport Clinic. They've expanded the availability of appointments, including same-day appointments, so that we can be more accessible to folks here in the community. We have successfully completed 2 joint commission reviews for the Veterans Administration. If anybody's ever gone through a joint commission review, it's a very big deal. There's a lot to it. I mentioned that we've been recognized as a health center, health quality leader for 4 years, and as a patient-centered primary care home since 2013. And primary care has also earned 100% of the metric incentives that were available to us. We're pretty proud about that. We have increased our billable encounters 65 to 70%,
Wow.
which is huge. We were seeing approximately 8 patients a day about a year ago. We're now seeing 13 to 14 a day, and our goal is 18.
Wow.
We have completed a reproductive health site review, and we provided more clinic days of primary care and behavioral health services in the schools than we have in prior years. And we're kind of proud of the fact that the Newport High School student leadership class identified our school-based clinic in the Newport High School as the recipient of the fundraising effort that they do every year. And a team of those students came and presented here for the Board of Commissioners. It was really special. And we have recruited 3 bilingual providers, and by providers, I mean people who can write prescriptions. So that's sort of the language that we use, because sometimes they're physicians. They could be a nurse practitioner, they could be a PA, but we sort of collectively refer to them as providers. So goals and objectives for primary care. Again, they want to achieve 18 patients a day. That kind of puts them in line with national averages. And a goal is to increase healthcare for students in our school system. Right now, we are working to get the numbers of students that we see each day in the schools up. We were kind of at a dismal 3 to 4 a day. We're working with the school district to increase those numbers through marketing efforts, making sure students are aware that we're there, overcoming other barriers. The school, for example, thinks the fact that sometimes when students go to our clinics, the door is closed. So that is a barrier to a young person. If the door is closed today, it's always closed. So we've applied for grant funding to get community health workers in those clinics so that the doors are open, and generally working with the district to just make sure that students are aware of our services, that in fact our clinicians are real clinicians. They're real providers. And so, you know, there's just some misconception there. So a lot of work going on there. We're working to provide greater staff coverage depth within the VA program. In order to work in our VA clinics, you have to have a certain level of credentialing and certification. And a lot of that's tied up with the VA itself. It's just not simple. It takes several months to get through. So we're working towards that. This year, we must recompete to continue to be the federally qualified health center, and we are working on that. I believe that application is due in July, and so a lot of work is going into that right now. And overall, we're just really working to re-engineer the overall community health center, which is how we call the federally qualified health center, by the way. Its formal name is the community health center. So we're just really working to re-engineer the entire operation. We're working with a consultant. We've started with client access, and now we're moving to our care team model so that we can just really make sure that we're lean, that the services that we're providing reflect the quality that we intend for the folks here and here in the community. And that people are aware that we're here. The quality of our services, I think parallel the quality of healthcare services you can get anywhere. And we really just need to do a better job of making sure that the community knows.
Director Romero, the competitive part of this, just semantics here, or recompete? I mean, what?
Literally, we have to recompete to continue to be the federally qualified health clinic.
Can you describe what makes it competitive at all?
The federal government will issue a notice of funding availability, and then we will compete for it. We stand a really good chance of getting it.
Good.
I think based upon the fact that we are the federally qualified health clinic, we have facilities, we're in the schools and so forth. But it's a lot of work. I mean, there's a lot of information that has to go into it, a lot of data. And we have to define the services that are under the scope of the federally qualified health clinic, and the services that are under scope are really important to define, because as a federally qualified health clinic, the services and more importantly, I guess, the service providers operating those services are indemnified, meaning that that they are indemnified from liability.
Thank you.
A lot of work is going into it.
Chair Miller, if I may ask, and then that is always tied to the tier section. So we're in tier 4. So if we were in tier 5, we would get a little better opportunity.
You're really pushing for this.
Well, and I just, with the, if I may, Chair, is the presentations for the last week and this week, we're on top of it. This county is top shelf. So let's continue that. And if we can get to 5, let's get to 5. Because we're closer to 5 than we were when we were at 3. So I'm always striving a county to work and and get as much funding from that portion of our, of that bucket, if you will. And when you're the best, they look at you and they say, gee whiz, these folks are doing it. These folks are presenting. These folks got good operations. So let's support that. And so I encourage us to get to that tier 5 and thank you, commission. Thank you, chair.
Yeah, shakers.
Yep.
That's
That's great.
And, clearly, I mean, that's part of what the whole re-engineering effort's about.
Exactly.
It's really just looking at our overall operation and just figuring out how we can just continue to improve. We're working with a great consulting firm. I think it's fair to say that other FQHCs in the state have started to reach out to us to learn about how we are increasing the numbers seen, or even just to inquire, how are you guys doing? We're having trouble.
It's fun to be the best.
I don't know if we're the best, but we're.
Oh, yes, let's be the best. Let's be the best and let's be the best county in this state. And that way we can get our funding and stuff. Thank you. Thank you.
Well, and that billable encounters, it's increased a lot. How do you specifically slice out those billable encounters as opposed to others? I mean, is that part of the marketing strategy too, of helping people understand that these are top shelf services,
So the billable encounters are literally tied to, there are people in our clinic. And they're seen by our providers. And so the way that we are increasing them is just really a structured process of looking at, for example, our templates, how we schedule our patients. Doing things like reminders, having those same day appointments, really focusing on patient access. We're about to begin to launch some marketing, and to be honest, we had held up on that because we were still here in Newport in the 1010 building, and many of us have been in there, maybe not you, Mr. Heath, but it is a very small space. And so really, even when all of the staff were present, it was crowded. So now we're in a more spacious space, and we're kind of in a position to really be able to market our services. So it's sort of a combination of more people knocking on the door, while at the same time looking at the internal processes, looking at how we schedule. But I mean, you can get really down in the weeds. It even gets down to our electronic medical record. And are we using it? And do we have smart phrases? And do our providers know what those phrases are, so that the 20-minute appointment doesn't take 40 minutes to document? And so there's just a lot of moving parts to it.
Yeah. Thank you.
Sure.
I do have one question. So one of your successes this year was completing a reproductive health care site review. Like a couple more sentences on what that is. Yeah.
So we're recognized, and I may have to have Ann follow up with you afterwards, but we're recognized as a reproductive health provider, and the Oregon Health Authority comes in and really just does a review to make sure that the services that we're offering line up with the regulatory expectations of operating that program.
Great. Thank you.
Okay. Just some of our metrics, primary care saw 2,773 unique patients and provided 7,469 appointments in the outgoing fiscal year. Our school-based health center saw 465 unique patients, or 1,119 appointments. And collectively, the number of veterans that we serve are 1,450, 1,200 here in Newport and 250 in Lincoln City. The number that we serve is defined by the Veterans Administration. We also see veterans in the primary care clinic, just, using the insurance that they have available to them as veterans, but there are specific individuals on the veterans panel that we see and that they contract with us to see. And then I think for them, the change that they've identified is opening the Walport Clinic and the remodel and relocation to Nice Street. These were big lifts for us this year. So that is primary care.
Wonderful.
Thank you.
Yes, thank you.
For the presentation. Very, very
Well, I-
informative. Perfect.
Oh, you do? Oh,
Yeah, we're gonna keep going.
Oh, I love it. I thought we were done.
My apology.
I'm gonna move into public health, and public health has a lot of moving parts to it, and you'll see. Public health is 18 of our 29 departmental funds. And, you know, without reading to you, you can see them all here. And I'll just kind of go on that. to look over that. And they tend to cluster in 4 areas. And I'll go over that in a minute, but just quickly, this is the funding of large work. And again, you can see the dip there, and that's attributed to the COVID funding. Public health got a lot of money during the pandemic, and so, yeah, so that there's still funding there, but it will back out, I think, by June and next year. And then similarly, the pie chart, and 68% of the public health budget is comprised of personnel services and 16% of materials and services. So again, there's sort of 4 cluster areas. 3 of them have program managers that manage them. So I'm just gonna go through them, and there's a lot of detail in here, and we'll just go through it. And if you have questions, let me know. So first of all, we have environmental health, and environmental health participates in the planning and enforcement of protocols, practices related to solid waste management. Our environmental health staff license all the restaurants in the community, including bed and breakfasts, mobile units, any of the festivals that spring up. Our staff are there giving folks temporary licenses. We inspect and license all of the travelers and accommodations. That would be every single hotel in the county, the motels, the swimming pools, the hot tubs, the RV parks, and camps. They also inspect daycare centers, the correction facilities, school kitchens. They monitor 47 public water systems, and they provide certificates of death and birth. So the goals that they have identified for next fiscal year include licensing the 625 facilities, conducting 7 water surveys in 2023 as assigned, and responding to all water quality alerts within a timely manner. So an alert might be somebody takes a water sample and E. coli shows up in it, or something of that nature. That would be reported to us. We would go out, we would monitor it as corrective action is taken to just sort of monitor the levels of whatever it is we're monitoring for and report back to the state. So here are the metrics that they shared. They completed 1,286 inspections and licensed 620 facilities. So what this tells you is that sometimes they had to go back more than once. 6 water surveys, 22 water quality alerts. They reported 275 births, issued birth certificates 132 times, or help people get birth certificates. You don't always have to come to us to get them. Assisted for individuals get paternity records 5 times, and or help file affidavits to correct birth certificates. Registered 696 deaths and issued 3,461 certificates. And the reason is people usually need more than one. So that's.
Yeah, you always,
Oh.
yeah, Chair. You always like, why is that so different?
Okay. So now I'm going to move on to another cluster of services, and these are the activities that we call maternal child family health. And so there are different programs that hit the maternal child family health cluster of services, and they include Babies First, Family Connects, Parents as Teachers, and Oregon Mothers Care. And these are really basically designed to prevent adverse pregnancy outcomes, to support children and families. Parents and Teachers, for example, really works with young families to help the parents become their child's first and best teacher. So they really basically work with our youngest citizens and our young families. Our Nurse Family Partnership Program is an evidence-based program. And it supports vulnerable parents who are pregnant with their first child. And this particular program does have a state match to it, so it does not require the county to match it. We provide the Cocoon program for medically at-risk infants, toddlers, and their families, and we can support them up until the age of 21 if needed. And also under this work group falls our women's, infants, and children's programs. So WIC, the WIC program, and of course, I think most people know about that. It's a nutritional and supplement program. I found this slide, and as I really think it's important I thought it was important to include in light of the fact that we're asking for 625,000 from the general fund or for any continued funding. And this is in this article, basically, it's setting the facts straight about Medicaid. So Medicaid coverage of low-income pregnant women and children has contributed to declines in infant and child mortality, reduced teen mortality, long-run educational attainment, reduced disability, lower rates of hospitalization and emergency department visits later in life, and second-order fiscal effects, such as increasing tax collections and being fiscally self-sufficient in adulthood. So these dollars are really an investment in the future citizens of this county. Major accomplishments they've offered, they include providing childbirth education classes in Spanish and Mom through a mini grant. They have reconvened the Maternal, Child, and Family Health Community Advisory Board, and they've recruited 30 individuals to be on it. That's a big achievement. Most of our boards, you know, we might have like 8 or 9 or maybe even 12. But to, you know, really to find 30 individuals who are interested is, you know, quite an achievement.
The Commissioner Miller and I share a seat. We can't be there together, so we go.
Let's see, we were awarded a grant for the Nurse Family Partnership Program. Our crew was actually one of the first in the state. And so this grant has allowed us to expand into Lynn County, mostly to support them to start up the program. And in collaboration with Lynn County, we've been able to hire a breastfeeding care counselor. And we've implemented texting features to remind individuals of their WIC appointments. Goals and objectives they've include increasing community knowledge of programs through the community advisory boards and outreach, developing you're going to see this all through all of our work. We're just really working to integrate diversity, equity, and inclusion in all of our work. So the fact that our program managers are including it in the material they send demonstrates that we're all committed to it, I think. Reach at least 85% of caseload assignment. In some cases, the individuals that we may see are identified for us, and then we have to reach out to find them. And so the goal is to basically connect with and engage 85% of them. Another goal is that at 6 months of age, an infant is still breastfeeding, or at least 45% of them are. Implementing the breastfeeding peer counseling expansion program, and then reopening satellite WIC clinics in Lowellport and in Celeste.
Director Romero, our budget committee member, Kristen Dawn is, hello, come on up, come join us. We're glad you made it.
Want me to start over?
She's pretty quick. So. Thanks for joining us. Yes.
So I continue it?
Yeah, yeah.
Yeah. Metrics they've shared, maternal child home visiting, total visits 1,137, and they enrolled 100. I'm just gonna kind of move quickly through these. Enrolled 155 new clients into the Babies First and Cocoon programs. With the Nurse Family Partnership, they served 60 families, which included 50 children, and they provided 1,134 visits. The Parents as Teachers program provided 1,165 visits.
Wow.
For our WIC program, they've kind of shared how they presented the data. In January of 2023, they had 40 new enrollees. They're at capacity, which is 1,023 individuals, and they completed 479 appointments. And breastfeeding is initiated in 99% of the individuals that they support. They've also included data from their last full report, which is 2021. And you can see at that time they were serving 856 patients. You know, all across our work during the pandemic, the numbers dipped. So you can see they've gone up significantly since then. Significant changes, case manager and home visitor. We have 2 individuals in this work unit that are qualified translators. So they've received a certification at the qualified level. There's qualified and certified, and qualified is a written test, certified is a oral test. They've added an assistant program manager, which really was a reconfiguration. This group of services originally had 2 separate program managers. They've combined them with 1 manager and then an assistant program manager. They've implemented a new data collection system, and they received a grant to facilitate childbirth education classes in Spanish. And the WIC work unit has resumed distribution of farm direct checks. So I'm going to move to the next cluster, which is disease prevention and health promotion. And this includes communicable disease, health promotion, our harm reduction efforts, and overdose prevention, our COVID-19 response and immunization. So
we're in public health right now, so.
yeah, which is 19 of our 29 fiscal departments. So their responsibility is to investigate and control for the transmission of communicable diseases and to investigate outbreaks and, you know, basically help put in place control measures. Harm reduction basically works with individuals. It's a low barrier program that works with individuals who have substance use disorders and provides services as defined by the state and at the federal level. And this would include outreach, case management, needle exchange programs, referrals to services, help with getting shelter and so forth. This work unit also provides community health education related to suicide prevention, tobacco use prevention and cessation, alcohol and drug prevention, and overdose prevention. So really all of our community education programs sit here within public health. And accomplishments that they've shared is that they've implemented a closed loop referral process for individuals with hepatitis C through our federally qualified health center, meaning they've made the referral and they've made sure that the individual got services, referrals were made, and so forth. So that's generally what we talk about when we talk about closing the loop. They support the Lincoln County School District vaping campaign. They provided many COVID-19 vaccination events in English, in Spanish, and in Hmong. And they sponsor the Oregon Liquor and Cannabis Commission responsible sales training. More accomplishments. They partnered with the Newport High School to provide fentanyl education and outreach with small cohorts of students. They've expanded harm reduction into South County, provided 6 Narcan trainings since December 1st, and they've started developing internal dashboards that we will be including on our internet. They're really nice. I mean, they're very detailed, and I think once we have them ready to go live, the community will be able to really just access a lot of data regarding a lot of the work that we do in public health. Their goals and objectives, reduce the ease of access to alcohol for youth in 8th and 11th grade, and they want to do that by 3%. And let me see, Apparently in 2020, 47.6% of our eighth graders reported that alcohol was easy to access. They are working to establish local emergency response plans to assist and identify with overdose outbreaks. And they're working to improve access to Narcan and naloxone. Metrics that they shared include that they have worked with our legal department to develop a tobacco retail density ordinance. It's been drafted. They have, I think, presented the draft or their efforts at the board level, and I think more work is to come on that. And so that would basically create some what am I trying to say? The proximity between where tobacco sales occur and schools will be, there would be limitations there.
I see.
Changes. We moved our overdose prevention efforts from behavioral health to public health. We, with regard to COVID, we no longer investigate at the level that we did. We now only will be investigating outbreaks, major outbreaks. And we'll really step down the vaccination events. We've hired a full-time disease intervention specialist, and we're collaborating to refer the hepatitis C case individuals with hepatitis C with an indication of high risk exposure to our harm reduction services. Let me see. And then the final cluster is which we're just calling other public health programs. These particular programs report directly to our division director, Florence Portell, versus having a program manager. And so we are working towards national public health reaccreditation for our overall public health division. We're engaged in a variety of modernization activities. So we've been able to hire an epidemiologist, do a lot of data analysis. We have an equity coordinator. We're really expanding our community partnerships. We're just working on community communication in general. This is sort of where some of those dashboards are coming into play. We are working on a climate adaptation plan in collaboration with Benton County. And so basically that plan looks at the effects of health on the population with different climate change events, and then what might be needed to address or mitigate those effects. And I think we all know that we've been working on a community health improvement plan at the regional level. At this point in time, efforts are underway to figure out what the top 3 priorities are. Once we know, we'll be working collaboratively with our regional partners to put a plan in place. And basically, we're just really working to develop plans to prevent, protect, mitigate from, and prepare for emergencies that might come our way. And that really falls within the wheelhouse of public health. Major accomplishments that they've shared, again, the equity assessment, the climate assessment and adaptation plan, regional health assessment that we've been a part of, the dashboards that I've mentioned. And we've been able to create some new positions that have just really, I think, modernized and increased the professionalism of our overall public health division. And I mentioned this earlier, we partnered with a lot of community organizations and a lot of volunteers. Many volunteers stepped up and contributed to the COVID response. And so I think we're pretty proud of that, not just because of what our public health division was able to do, but just I think because of the community response, the partnerships that we made, and the volunteers who were part of the process. Goals and objectives. Some of them kind of are repeat, working toward national reaccreditation, We're looking at our emergency operations and public health risk communication plans. In fact, we're just really in the process of totally reviewing and revamping our overall emergency response at this point. We want to finish the climate and health adaptation plan. We're implementing our equity strategic plan. We're finishing our dashboards, and as we get our emergency response plan developed and defined, then of course we'll work to educate our entire workforce, not just in public health, but across all of our divisions. Let's see what the significant changes are. I think what they contribute is just that the Oregon legislature really invested in public health modernization. And because of that, we were able to really, I think expand not only our staff, but the functions that we're able to achieve, as I've mentioned throughout this presentation. So I'm not going to repeat myself at this point, but I think that is significant. The shift at the legislative level has just really, I think, upped our game overall. And then finally, Health and Human Services Administration, or the fiscal department that is Health and Human Services Administration, is embedded within the Public Health Division. And so that would be where my position falls. It's where all of our fiscal staff fall. It's where our quality and risk management staff fall. It's where our public communication officer sits, where our project management work is done. All of our third-party billing for behavioral health, primary care sits within administration, and really just all of the overall administrative support that we have in place to support the activities of the divisions that I shared with you. Going forward, it's my understanding that we're going to be able to actually pull this department out and put it in its own fund. Having this department in any division inflates the fiscal picture of a division. So we'll be able to pull it out, put it in its own fund, and so next year we'll have fun. And I have reached the edge.
Question. So when we think of dashboards, is that maybe infographics? Is it air quality? Is it, vaccination? I mean, are those types of things that help us,
It helps us
see
drill down.
information?
It helps us see trends over time for, say, sexually transmitted diseases, as an example. But it will also help us drill down into the ages. So what we're seeing by age, as an example. And so that's really what our epidemiologist is working on.
Okay.
And so it's, I've seen a presentation of it. It's really a lot of good information.
Okay.
And we intend to put it on the website.
Gotcha. Okay. Awesome.
Chair Miller, if I may, I'm going back a little bit in your presentation. The youth, and when you go to the high schools and the schools, you're getting very low participation from our young youth. What can we do as a county to encourage the youth to engage in something that's very difficult to talk about? And how can we get into this classroom or into the schools and make it more comfortable for our youth to have that conversation? And what can we do as a county to help you facilitate that?
Well, I think it's a really good question. And I think the first step is to ask the school how they can help us help ourselves. And so we had that meeting. We were able to meet with leadership in the school district, myself, Marie Laver, and Allard Robinette, and to just talk with them about it. Because they want us there, right? I mean, there are huge advantages to having healthcare clinics in the school setting.
Truly.
Not the least of which is you don't have to take off work to take your kids.
Well, it's sort of in-house,
Yeah.
if you will.
And kids also miss less school.
And they miss less school. Yeah.
Mhm.
And the kids can manage their own healthcare, and especially when, there are kids in high school. So.
And giving them that opportunity to manage. And I guess we're trying to give them those tools to manage that. And so as public health and your department, to enhance that engagement, if you will. So they're not afraid to come up and have that conversation, even though it's difficult.
So there are a couple of things that we're working on, and one is literally just marketing,
Yep.
letting students know, letting parents know, we're there, here's what we can do. We're healthcare, right?
But we're not the enemy. We are, yeah, we're not the enemy. And I think healthcare has that stigma that, oh golly, I'm gonna go to the doctor and I'm gonna get sick, or I'm gonna talk to the nurse and I'm not gonna feel well after I leave. And so, yes.
But there are other things that we're working to do, you know, like the barcodes that we see now, you can put your phone up and press on the barcode
QR
and see the
codes.
menu, right, in the
Yeah.
restaurant and whatever. So we're working to get those in place so that if the door is closed, a student can actually use their barcode to make an appointment.
Good.
We have applied
Sure.
for a grant with HRSA. We've passed the first stage, so we're hoping that we'll go forward to actually have community health workers on site that are funded through federal dollars. So that the door is open. The school believes that the biggest barrier is that the door is closed. A door is closed. Unfortunately, though, the cost of having staff and healthcare providers in a clinic is expensive. Very expensive, because when we're talking about people who can prescribe, we're talking about some of the highest paid employees that we have in the county. So our budget is not such that we can pay people to wait.
Sure.
So one of the things that we have requested in this grant is also telemedicine equipment, so that youth in Taft, for example, may not have a provider on site, but that provider might be in the Walport School and they may have an appointment, so that the student would be able to access the healthcare appointment through a telehealth visit. We've also talked with the school about the fact that the majority of their students are actually K-6, and working with them to have their staff escort the younger folks to our clinics in the high schools. That's not possible where it requires a drive. So for example, in Lincoln City, there's distance. I think they said it's an 8-minute drive from the K-6 facility to the high school. So we may not be able to do this there, but in some of our other schools, literally you can walk the child over to the healthcare clinic, and they're willing to devote some of their staff time to make that possible. Basically, they have indicated to us it's important to them that we're there, and they will help us market and get the information out. And so for us, it's a balance of communicating our availability and at the same time balancing that with the demand, if you will, and our staff, so that we're able to grow the program, but not do it in a way that puts us in the red financially.
Thank you. Thank you.
Yeah.
Chair Miller, thank you. Thank you.
Absolutely.
Commissioner Jacobson?
Nothing for me.
No. Okay, well, thank you very much.
Thank you.
No questions for me? Thank you. Well done.
Appreciate it.
66 slides.
Did anybody else take longer than we did?
But it's as big as you are.
Yes, that's right.
Well, we very much appreciate the support of the Board of Commissioners. I think we've all always said that. And we appreciate the commitment, and it's a lot of time for the two of you to get to them, so we appreciate it.
Yeah, well, and we appreciate you too. And I
It's
think the
been
point
great.
you made about contributing to the community, it's all integrated, and the healthier we are, it just makes a big difference.
We all live in the county commission.
Yeah.
you.
So looking at our agenda, that was community questions. We're going to move into questions for the public by the public. Yes.
I kind of
you
like
like
that.
that?
Just bring people in off. the
Yeah,
street
we'll
to
just-
see what they
It's a little bit
do.
different.
We could call it like a guerrilla civics education or something.
I think PIO Lip is saying there's nobody online, and we have nobody signed up, I would assume. And last call for the committee? No? Okay, so we will recess the public hearing. Am I right there, Council? You'll continue to May 23rd, 6 PM. We're going to be here,
That's tomorrow.
same room. Yep. And thanks for joining us tonight and thanks for presenting to us and thanks for everybody who participated, staff and everyone. Have a great evening.